All right, Doc, so let's dig into the elbow exam. Elbow's not as complex of a joint as like a shoulder, but there's still some very relevant tests that need to be done to detect what the pain generator is in and around the elbow. And of course, there's many things that can happen at the elbow that affect distally to that. So it's important to do a good workup of the elbow, even when you got sometimes wrist and hand symptoms. So range of motion is where I usually start most of my exams. So all the elbow can be done seated basically. And so there's just 4 cardinal movements. So now bend your elbow up and fully straighten it, okay? And then rotate your wrist in as far as you can, and then rotate your wrist out as far as you can, okay? Sometimes I'll do that with the elbow bent. It's a little more accurate, so rotate in as far as you can. Pronation, and go the other way. Supination, okay? Then of course you always want to test passively. So that was active, passive, 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 and passive. So flexion, extension, pronation, and supination. Noah, don't let me pull your arm out. Resist me. Noah, push. Good. Noah, rotate your wrist in, pronate, rotate your wrist the other way. Resist. So boom, boom, boom. You can screen through active, passive, and resist it very quickly, and noting if there's any pain or limitation of range of motion. There's just a few basic orthopedic tests. Probably the most common condition that we will see at the elbow, of course, is lateral epicondylitis. Of course, they don't use the term tendinitis much anymore. It's now called tendinosis or tendinopathy. Okay? The most common test is Cosen's test. The arm is straight, the wrist is flexed. No, I'm going to push your wrist, try to push your wrist down, but you're just not going to let me. You're going to resist me, so don't. There we go. And if that reproduces pain in and around, let it down. There, no, in and around the lateral epicondyle area. That's usually significant for tennis elbow or lateral epicondylitis or epicondylopathy. And if it produces pain right over the radial head, sometimes that can be a condition called radial humeral bursitis. Okay? The other test that I do for tennis elbow is called Mills test. And this one, you want to get their elbow flexed, you want their wrist flexed, their fingers flexed, and what you do is you fully flex the elbow, then you extend, keeping that wrist flexed, the fingers flexed, and fully straighten right there. And that'll put a lot of pressure right over that lateral epicondyle area. So in review, it's kind of an all-one fluid motion. So flex the elbow, flex the wrist, the fingers, and then extend with full pronation all the way to that position. That is a really good test for picking up tennis elbow lateral epicondylitis. Of course, the opposite of that is medial epicondylitis, which happens right over the medial epicondyle. This one, we just do a test called golfer's elbow test. The wrist is just the opposite of Cosen's. The wrist is flexed, and we're going to keep it that way. And Noah, I'm going to push down here, and you're going to try to keep your elbow a little bit bent too, okay? So don't let me push your wrist or elbow down. That. It's resistant of the wrist, resistance of the elbow. If it reproduces that pain right up in that area of the medial epicondyle, that is significant for medial epicondylitis. So those are going to rule out your most probably common 2 conditions that you'll see at the elbow. Sometimes you'll see some ligamentous injuries like in pitchers and things like that, so it's important to do ligamentous instability tests. And those are quite simply accomplished with the wrist or the elbow in full extension and doing a lateral to medial test. So grasping below and gently pressuring that in. And that will test that medial collateral ligament. And then of course, we would do just the opposite and stress medial to lateral, testing the lateral collateral ligament. Just like we showed Tinel's testing down at the wrist in a couple of locations, there's actually about 4 or 5 locations where you maybe would do Tinel's at the elbow. The first, of course, is the cubital tunnel, the funny bone area, right through here. Ulnar nerve comes through here and goes to these 2 fingers. So we know it can get trapped in the tunnel of Guyon. We talked about that in the wrist exam, but it also can get trapped in this cubital tunnel. So we use our handy reflex hammer and we tap right into that area to see if they get distal reproduction of the ulnar nerve symptoms. Then we come on the other side of the olecranon and we hit right in the radial groove. That can be, of course, radial nerve or the posterior interosseous nerve. Then I usually come right into the belly of the supinator muscle, and I will tap right in there. And that is, you can get a condition called radial tunnel syndrome or supinator syndrome. Posterior interosseous nerve can be entrapped right there. The other area that's important to do, and this is a little known spot, but about 8 centimeters proximal to the cubital tunnel and the medial upper arm, there's an area right in here called the ligament of Struthers. It's pretty tender on some people. That is an area where the ulnar nerve comes underneath this ligament here, and it can get entrapped right there. So sometimes you'll want to Tinel's tap right over that to see if that reproduces their arm symptoms. So ligament of Struthers, cubital tunnel, radial groove, radial tunnel are the main areas that you would want to do Tinel's testing around the elbow. Oh, one other one, the pronator teres muscle. So coming right in through here, we know with carpal tunnel that can be a site of entrapment too. So we would Tinel's taps right over that to see if that reproduces median nerve related symptoms into the hand. Sometimes the Tinel's test at the wrist will be negative for carpal tunnel, but it'll be positive over here for pronator teres syndrome. So then, of course, you palpate. You palpate the relevant areas. If it's a carpal tunnel case, you definitely would palpate the pronator. If it's a lateral epicondylitis case, you would palpate the radial head, the supinator, and then the muscle that's most commonly involved with lateral epicondylitis is the extensor carpi radialis brevis. So you definitely want to palpate through that muscle area there. If they have ulnar nerve involvement, you would palpate in the cubital tunnel, right here through the flexor carpi ulnaris, and I always palpate up into that area, the ligament of Struthers. You get the idea. Palpate the relevant anatomy and the tendon sites. And then, of course, medial epicondylitis, palpate the medial epicondyle, and lateral epicondylitis, palpate the lateral epicondyle, noting your exam findings, okay? And finally, some cases of elbow would need an x-ray, especially trauma. So you got your classic 4-view x-ray, and I do a lot of laser and shockwave, which I always track my results with those cases. So it's good to do an upper extremity index to track their disability level related to their elbow at the beginning of treatment and at the end. That is, folks, a pretty good elbow exam right there. Thank you.